medial epicondylitis of the elbow. Medial epicondylitis, it's also called golfer's elbow. It's an overuse syndrome caused by an overload of the flexor pronator mass at the medial epicondyle of the elbow. Medial epicondylitis is less common than lateral epicondylitis and occurs more in the dominant extremity. Medial epicondylitis is common in sports and in jobs that require lifting more than 20 pounds. The medial epicondylitis affects individuals whose activity involves repeated forearm pronation and wrist flexion. This will cause microtrauma to the flexor pronator group due to repeated eccentric loading of the tendon at its origin, which will involve degeneration, tendinosis, and tendon disruption, and angiofibroblastic hyperplasia, and eventually fibrosis. In fact, it does affect all muscles of the common flexor tendon except the palmaris longus. This flexor pronator mass of muscles reduces the force experienced by the medial ulnar collateral ligament anterior band, which lies deep to the pronator teres and flexor carpi radialis muscles. In fact, this common flexor pronator muscle origin provides dynamic support to valgus stress in the throwing elbow. The medial ulnar collateral ligament anterior band is the primary medial stabilizer of the elbow against valgus force. There might be some associated conditions such as ulnar neuropathy or insufficiency of the ulnar collateral ligament, especially in throwing athletes. You may find the patient may have occupational conditions such as carpal tunnel syndrome, lateral epicondylitis, or rotator cuff tendinitis. Symptoms: patient will have pain and tenderness around the medial epicondyle, which is worse with resisted forearm pronation and wrist flexion, and worse with gripping. Examine the patient for associated conditions such as valgus instability and ulnar nerve symptoms. How do you examine for valgus instability? Examine the valgus instability by valgus stress or moving valgus stress test. How do you examine for ulnar nerve symptoms? Tapping on the nerve in the cubital tunnel, it's called Tinel sign, can produce symptoms of paresthesia and pain. It's like hitting the funny bone. You can also use the elbow flexion test to diagnose for ulnar nerve symptoms, which will involve maximum flexion of the elbow with forearm pronation and wrist hyperextension for about 30 to 60 seconds. So how do you examine for the medial epicondylitis? Flex the involved elbow to 90 degrees. Keep the forearm supinated, and the examiner will palpate the medial epicondyle of the elbow. The other hand is placed over the volar aspect of the wrist and hand. The examiner will ask the patient to move the hand and the wrist into wrist flexion and forearm pronation, while the examiner is resisting the motion and feeling the epicondyle. A positive test occurs when the patient feels pain in the medial epicondyle, which the examiner is palpating. So the patient will say, yes, the pain is there, and that may indicate the patient may have a medial epicondylitis. MRI is helpful. It will evaluate the associated pathology, for example, ulnar collateral ligament injury in overhead throwers, and evaluate if there is any injury to the flexor pronator origin. Usually you will find increased signal in T2 images that may indicate tendinosis or tendon disruption. EMG nerve studies could evaluate ulnar nerve compression. The differential diagnosis is medial collateral ligament injury, cubital tunnel syndrome, cervical disc herniation, triceps tendinitis. It is very important to differentiate between medial epicondylitis and an ulnar collateral ligament injury. In the ulnar collateral ligament injury, the pain is posterior and distal to the medial epicondyle. Treatment. The main treatment is non-operative with activity modification, rest, ice, therapy, counterforce bracing, and anti-inflammatory medication. The result of operative treatment of medial epicondylitis is not as good as operative treatment of lateral epicondylitis. So give the medial epicondylitis more time for conservative treatment. Injections. You may use an ultrasound. You do not want to use multiple injections. You'll do steroid injection into the common flexor tendon peritendinous area. Don't inject the tendon, inject around the tendon. Injection is close to the ulnar nerve, so be careful when you give the injection for medial epicondylitis. The corticosteroid injection does not have any impact on the surgical result. Surgery. Do open debridement and reattachment of the flexor pronator group, especially if you try the conservative treatment for 6 months and it fails, and especially if you have the correct diagnosis. It will give good to excellent outcome in about 85%. Most of the patient can anticipate improvement and resolution of their symptoms without surgery. However, there are some group of patients that may need surgery. The majority of patients will go back to their prior activity after surgery without any loss of flexor pronator strength. You may also want to do cubital tunnel release for concomitant ulnar nerve symptoms. The worst outcome occurs when ulnar nerve symptoms are present preoperatively. When performing ulnar nerve decompression at the elbow, the surgeon must be aware that the medial antebrachial cutaneous nerve crosses the field 3 cm distal to the medial epicondyle. Complications. It is more difficult to treat medial epicondylitis than lateral epicondylitis. Medial antebrachial cutaneous nerve neuropathy. The nerve is in the vicinity of the incision. Concomitant moderate or severe ulnar neuropathy treated with nerve transposition leads to worse outcomes compared with no ulnar nerve pathology. It is the severity of the ulnar nerve neuropathy that correlates with the outcome of patient treated operatively for medial epicondylitis. Thank you very much. I hope that was helpful.